like I said earlier, to be able to commemorate this day. This day is celebrated every second Saturday in the month of October by people who have been impacted by life-limiting illnesses. Now here in Uganda, there is need to prioritize palliative care policies and services. Before you is a panel of discussants that I'll be introducing to you later on. But of course, I would also like to welcome all our online viewers and participants wherever you are. You're watching live on NTV, Facebook, and YouTube, and you're also watching live on Palliative Care Association Uganda Facebook and YouTube Facebook pages, sorry, I beg your pardon. Thank you so much for being a part of the discussion. And before we start and get into the discussion, I would like to take this opportunity to invite our host, the man who's made it possible for us to be here and organize us despite the COVID-19 restrictions. I respect the fact that there's enough social distancing and would like to invite Mark Donald Mwesiga to come and share opening remarks and the objectives of this discussion and activity of the day. You're most welcome.
Thank you so much, Sophia. Good morning, ladies and gentlemen. Thank you so much for coming and for being on time. As you have heard, my name is Mark Donald Mwesiga. I am the Country Director of the Palliative Care Association of Uganda. We are hosting this event for commemorating the World Hospice and Palliative Care Day in Uganda together with the Minister of Health. The Minister of Health will speak, as you will be seeing, throughout the event. I welcome you all once again. For people who are here, we are very few people here present at the Sheraton Kampala Hotel, but many of the people are online, and we are doing this as the first of its kind. It's the first edition of commemorating the World Hospice and Palliative Care Day in Uganda this way. As you know, we have been gathering always, and by now we would be walking through the streets of Kampala to raise awareness and show cause and to bring everybody on board. We are going to commemorate this day in 2 phases. So we have an event starting now, but it will go on up to 1 p.m. The first phase is what we are on now. This is a high-level discussion where we have Ministry of Health, people who are implementing, people who are direct stakeholders, or people who are really doing the caring, people who are doing the service provision, discuss and give us an update on what has happened as far as palliative care is concerned for the last 27 years, because as you will be learning, and as you have put in your documents, palliative care services in Uganda have been here since 1993. After the high-level discussion, we will go into the voices for hospice. Now that will start at 11. That will also be a virtual event. The Irish ambassador will be chief guest at that event. It will continue, so we'll just transit, like we'll have a transition from this event that we have to proceed into the concerts. We have lined up a number of choirs, they'll be singing, and they'll be online. So I request that you remain available for that event as well. Let me take this opportunity to introduce a few people who are here, and then I'll mention the objectives of the day. We have invited a few people to come and be present here, and mainly these are PICAO member organizations. So I would like to request everybody representing a PICAO member organization to stand up for recognition in the room. I can see the, thank you so much. Yeah, from Hospice Africa Uganda, Caroline, she's the acting chief executive director. We have David Kavuma from Malme, Uganda, and I'm sure the rest of the people will be joining. We also got some apologies for people who cannot come. We got apologies from Kawempe Home Care, and the other people will be joining us. We also invited, we are here with the board members of the Palliative Care Association of Uganda. And the board members that are already here, you can also stand up for recognition. Thank you so much, the board members, for coming. We also invited people who are who were on the board of PICAO formerly and who continue to support us in various ways. We invited Ms. Fatia Chiange. She was a board president for PICAO at some point in time. We also invited Dr. Jacinto Amandwa. He's on the way. Maybe he will be joining us later. And we also invited other people who were on the board who have not yet come. We also invited our former country director, Ms. Rose Chiwanuka. She's special to us. We also invited people who are life members of the Palliative Care Association of Uganda. We consider these as special people to us because they have decided to contribute to the dream of palliative care having its bigger home in future. For everybody to become a life member of PICAO, they contribute a total sum of 1 million Uganda shillings, which can be paid in installments, and they pay it in a period of 1 year. This money adds to a pool of resources that we are generating and gathering for our dream that one day we are going to see a bigger facility, a bigger home for the Palliative Care Association of Uganda. Later on, we'll be having some plaques to give to people who have become our life members. These are the objectives for these events. I have left out some people that I will introduce later who are very important. These are objectives for this event. We are here to share the vision that we have as the Palliative Care Association of Uganda, which is also the vision for our country, as the minister will be sharing, that palliative care should be accessed by everybody in need, everyone, the individual and their family who need this service in this country. We are here to share this and to make sure that the country knows and that all stakeholders can work towards achieving that. We are also here to raise awareness about the needs that the people have, people who are living with life-limiting and life-threatening conditions, people who need our care. We're here to raise their voices and to make sure that their voices can be heard by everybody, such that whoever has a contribution to make can make it to make sure that they support them. So we'll be having the people themselves speak to us. We are also here to mention that we need resources to make sure that palliative care services reach all the people who need them. So we are also here in a way to mention that we need funds, to raise funds. And that is why I mentioned the fact that we need palliative care services, that we need all of you to become members of PICAO, that we need all of you to become life members of PICAO, that when you buy a mask today at only 10,000, this money will go to a hospice and it will go directly to somebody who cannot afford a mask, but they have come for care at the hospice or a palliative care team to be looked after. There are people in this country who come and they are supposed to be attended to at a hospital, but they cannot afford a mask. And so we are trying to make sure that we provide masks for all of them. Like I said, we are organizing this event together with the Minister of Health. But briefly about the Palliative Care Association of Uganda, we are a membership organization. We are composed of 24 members. These are the organizations in this country. They are spread across the country. We also have over 1,200 individual members. Our vision is to ensure that palliative care reaches everybody who needs in this country. We do this through our mission, which is based on 4 areas of capacity building, advocacy, research, and resources mobilization. I'd like to thank you once again and wish you very good deliberations. But I'd like to thank again the Minister of Health for working closely with the Palliative Care Association of Uganda. This working closely has enabled us as a country to make some achievements. The achievements will be highlighted, and our board president wrote a statement. It is within your parcels. You can look at that statement. When I thank the Minister of Health, the entire team, I would like specifically to thank the people we work directly with. I would like to thank Dr. Jackson Amoni, who is the Commissioner, Clinical Services. Thank you so much for opening your office and for allowing us to work with you every day. I'd also like to thank Dr. Miriam Ajambo, who is the palliative care focal person, who has also been able to work with us very closely. Let me introduce the team of staff from the Palliative Care Association of Uganda. If you can all stand up wherever you are, and then I'll end there. They are mainly ladies, as you can see, but they make the things happen. We are a small team of 15 full-time staff now, and we thank God we are 15. We were 14 some time ago, and we are committed to make sure that we fulfill the assignments given to us by the members of the association. Kindly thank them for every good thing, and you can blame me for the bad things that happen at this function. Thank you so much, and I wish you a very good day and great commemoration as we stand together to raise the voices for those in need and for whom we all stand for whom we all need to receive the service. God bless you.
Thank you so much, Mr. Mark Mwesigwa, the Country Director, Palliative Care Association Uganda, for those wonderful remarks. And thank you so much, everybody, still again, like I said, for keeping time to make it for this function. Without dwelling or wasting any more time, I'd like us to get straight into the panel discussion, but I would beg to introduce to you the panelists as we have them here today. Starting on the other extreme side is Dr. Emmanuel Luyika, who is the Executive Director, African Palliative Care Association Uganda. You're most welcome. Then right next to him is Dr. Jackson Amoni, the Commissioner, Clinical Services, Ministry of Health. You're most welcome, Doctor. And the beautiful lady you're seeing seated right there in the middle is none other than Martha Raboni, who is a palliative care nurse and from Mobile Hospice in Mbarara. You're most welcome. Then you have Dr. Henry Dungu. Dr. Henry Dungu holds a lot of capacity, but today he is the board president, Palliative Care Association of Uganda. You're most welcome, Doctor. And right next to me is Miss Imelda Chichoncho, who is a caregiver still. Thank you so much as well for making it. Okay, now we'll get right into the discussion, and we just have a few minutes because we would like everybody to participate as you're watching us online. I would like to remind you, if you still haven't yet caught up and you're missing out on the discussion, please get right seated. We are streaming live on NTV, Facebook, and YouTube, and also streaming live on Palliative Care Association on both YouTube and Facebook. Please join the discussion. Dr. Dungu, I would like to start with you because I don't take it for granted that when we talk about palliative care, people know what we are talking about. I would like us to break off the medical jargon and use a simplified term to explain to a person who is watching us right now. When we talk about palliative care, what are we talking about?
Well, thank you so much, moderator, and good morning, everyone. I like the question. You know, people for a long time have not understood palliative care the way we understand it now. But it's all because of how things have been evolving. As you know, medicine is an evolving art. For many years, we referred to this as hospice, which was basically a care given to people where everything has failed. In around 1990, 1992, the World Health Organization came on board to define palliative care as the kind of care you give to a person, especially with cancer, when everything has failed. When you've tried this and they say, no, we can no longer do anything, now let's do palliative care. In around 2000, things changed. You know, with the evolution of a number of diseases, we see HIV, we see a number of life-threatening illnesses. A revision was made, and palliative care was defined as an approach with the sole purpose of improving the quality of life of a person with a life-threatening illness. Initially, it was life-limiting, but then it became life-limiting, you know, including prevention and early detection of those symptoms that make someone feel unwell. So that you don't wait for someone to first drop into the ditch, then you pick them. If you know that I'm going to give someone chemotherapy and it's going to make them sick, you think of strategies of preventing the complications they go through and you do that. So palliative care is an approach as of now that is holistic in nature, meaning that it is all inclusive, and it is for individuals of all ages with serious health-related suffering due to severe illness, and especially those, when it comes to near end of life, the needs of a person in terms of palliative care are enormous. And so a person is given more treatment. But palliative care begins from the time of diagnosis across the continuum of a person's illness. It is not only about end-of-life care. End-of-life care is just a very important aspect of palliative care, but as I would say, its intention is to make sure someone lives quality life.
Okay. So in terms of quality life and in terms of the service that you have explained, is it a service that is easily accessible and inclusive in the healthcare systems? Oh, most of the times, personally, I have heard, they have to first tell somebody who needs that kind of service, go to hospice. But it's not like any other service you're going to find within the hospitals.
And I'm glad about that, because initially, this service was provided at places called hospices, where you go and you are given treatment, to help you live until when you die. But now I think we know it that hospice is a philosophy of care that implements palliative care provision. But palliative care can be provided in any place. It can be in a hospital, it can be in a home, it can be in a specially built facility to provide care for people with life-threatening illnesses. In Uganda, palliative care is all-inclusive, because if something is on the minimum healthcare package of a national health system, it means anywhere you are, you should be able to access certain aspects of palliative care. So in Uganda, palliative care is embraced by the national system, and I'm glad the ministry has been, at the forefront of doing this to make sure that any person at any time who needs this kind of care is able to access it.
Okay, thank you. I'll get to you, Martha. Martha, as a person who is, offering palliative care in a remote area, I would like to find out, have you been offering this care for, like, say, 20 years? And what motivated you to join the service?
What really motivated me to join the service, when the palliative care came to Uganda, that time we were working in a hospice. We used to work in a hospital. The hospital had so many patients. Some patients would come with cancer, and at the end of the day, they'd say, there is nothing more we can do for you. And yet these people, they are not going to die. They are going to live till, and they have a family and they have responsibilities, but they are in so much pain. So when Professor Anne Merriman came, and he taught us about palliative care, and we started the service. So we had to look after those patients, because all along when I was working in the hospital, I used to wonder what happens to patients who go home and they tell them there's nothing more you can do. And these patients are still patients, they are still feeling pain, they are still ordinary human beings in spite of all their illnesses. So that's how I joined palliative care.
So having joined palliative care, what are some of your, can you have, I believe, that success story you can say? Because for your age and for the period of time, I can imagine there are certain times you might feel like you want to give up.
Well, that's one good thing about palliative care. When these patients come to our places, they are in so much pain, they are so distressed, they are so devastated, actually, the whole family. We are not looking only after the patient, we look after the whole family. And when you relieve somebody's pain, because one thing they will tell you, they have not slept for so many years. And you make short-term goals and say, look, at least tonight you will sleep. That is already a success. When the patient comes back, the next day is smiling, and the family is all calm. You really feel so good, and you just don't want to stop.
Now, how has the Palliative Care Association supported you in ensuring, you're able to reach your goal? Because I believe you go back with a smile at home when you're able to see a patient in lesser pain.
Yes. The Palliative Care Association of Uganda, it has helped to bring this awareness to all the people to know that there is this kind of help. It has supported us in giving us sometimes some resources. It has helped to teach the people, other health workers, to learn about palliative care. They have sponsored them, and these people have done a good job in other places. So it's not that I'm doing the thing alone, I'm doing it with all other people.
Okay. Now I get to you, Imelda. Imelda, you have a very interesting story that I believe would make great hearing for us around here. Caring for terminally ill close relative at home for a long period of time and with the support from the palliative care team. Please share with us briefly about your story.
Good morning, everyone. I'm called Imelda Chichonjo. I work at Entebbe International Airport with Civil Aviation Authority. I have an 80-year-old mother who was diagnosed with cancer of the colon in 1999 in Barara Referral Hospital. That's where the story starts. So after the first operation, she was taken on the ward, and then after some time, well, I was still a bit younger, but I remember we got a team from Hospice that came and introduced us to us the care that Hospice gives. So after discharge, of course, we had to go to they have a branch in, it's called Revi Corner in Barara. We were told about Hospice and the palliative care, and eventually they came to our home, just about 9 kilometers from Barara town, and that's how we came to know Hospice, and that's how our mom was able to live on, because we had lost hope, like she's saying. It's not only the patient that loses hope, it is the whole family. Because she never felt sick, and that was once, and then she was diagnosed with that cancer, and they were told by the medics that it was at an advanced stage, but she has lived for 20 good years, and she's 80 years old.
Wow. Okay, now, of course, out of curiosity, first, thank you so much, Palliative Care Association, for that kind of support, because it is very touching. 20 years is a long period of time, I would say. Is she completely okay now? Or do you still at one point keep taking her back for referral and ensuring that all is well?
Yeah, of course, after that, she got 2 more other operations. One was for the appendix, another one was for the colon again here in Zambia. And currently, she has she's functioning on 1 kidney. And we have brought her this side. I live in Entebbe, along Entebbe Road, it's called Kauku. And we have transferred her files to Hospice Makindye. So she's on that treatment, she's taking morphine, she's taking amotriptyline and some other. When she gets an extra, maybe another complication, of course, we've got to take her to Zambia. Sometimes we do it at home. Yeah, that's how we have lived with that cancer. And Hospice has given us a lot of hope that she can still live on. Because the home visits, especially the home visits, give her a lot of hope. When they come, they counsel her, they also talk to us, the caretakers, how to care for her.
Okay. Yeah. Martha, Imelda, what keeps you going? Because there are certain times at her age, you imagine the pain, you imagine the distress, and you feel like, I think after this phase, maybe, where do you get your drive from to keep going and ensuring that you keep taking her for all this palliative care support?
Like the doctor is saying, Dr. Huff is saying, when someone is diagnosed with cancer, sometimes you also think she's going to die then and there, or the patient's going to die then and then, or maybe like I've been sharing with people when I go to these workshops. These workshops have helped me. These workshops, when I attend them, they tell me how to keep moving. Then the other support that I get when she's counseled by the health workers that come home, I see her getting the hope. And when she gets the hope, I also think she can still live on. The strength that I get is, I think, spiritual. Sometimes we've got to pray with her, we've got to comfort her. And then when she gets the hospice staff visit her, she confides in them. When she confides in them, then she's feeling better. when she's feeling better, of course, I also feel confident that she's going to live on.
Okay.
Yeah. Of course, as a caregiver, I'm imagining there's another group that may not be able to handle these other complications that come by. For example, you find the elderly, the poor, the terminally sick. Like we shared one day with someone who had sickle cells. Yeah, it's a bit draining when you see someone in pain and you cannot do much. But you play your role and that's all. Yeah, you play your role and pray to God.
Okay,
Yeah.
thank you, Melda. Dr. Emmanuel, if I get to you, because palliative care and universal health coverage with a link to UN Sustainable Development Goals and comparing Uganda's progress with Kenya, Rwanda, and other countries. Now, the focus of the UN SDG is leaving no one behind. And Uganda is working towards those SDGs. What are some of the practical things that the Ministry of Health should do to ensure that palliative care is part of universal health coverage with target 3.8 of the SDGs?
Thank you very much, and thank you, Palliative Care Association of Uganda, for organizing this event. The question that you've asked is a very central question to improving services for all of us, because palliative care is for all of us. Within the context of the Universal Health Coverage 2030, we've also had the governments make that commitment to that political declaration, but they have also made commitment to the World Health Assembly resolution that was passed in 2014. That resolution focused on palliative care alone, and it had 9 areas. And in terms of the Ministry of Health, the first thing that needs to be looked at is the policy. It is also mentioned in the resolution, developing a national overarching palliative care policy. And then secondly, providing resources, providing money for patients to access the services, providing money to hire more health workers at all levels to provide palliative care. And when we talk about providing money, we get a bit jittery because we've seen that the African countries made a commitment in the Abuja Declaration to commit 15% of their budgets to health. And palliative care draws its money from the health budget. But in Uganda, our allocation to health has been declining over the last almost 8 years. And currently it stands at 5.9. So I think Uganda government should make sure that they work upwards towards committing enough money to the Ministry of Health. So the question is beyond the Ministry of Health. It's Ministry of Finance, it's Parliament of Uganda, it's the President of Uganda to ensure that the Ministry of Health has enough resources to meet those requirements that they have. The third point is access to controlled medicines. Now, Uganda has done very well. And in fact, if you look at the rest of Africa, we are a bit higher in the league. But that needs to go further down. And that linking that to a health service that can get to a patient's home, that's very, very important. You've heard Imelda talk about that component. It's very important that our health service gets to the patient's home, that patients can get palliative care. You can imagine if you have cancer, you have some bones that have secondaries from the cancer, and they keep putting you on a border to go to hospice. They should be able to find you in your home. And that funding aspect should also include the supporting of hospices to deliver the medicines and other services within the home of that patient. The other thing that needs to be looked at in this whole thing is basic support to the families, because it's also in the resolution. Families that have a patient with palliative care needs need support. If they don't have that support, they feel abandoned, they feel helpless. And if it involves costs, then it leaves people poor. So they need to be supported to access the services. So we need to see the Ugandan health system from the policy, the funding, to getting to the patient's home and providing the services as provided for in the package, which includes the human resource, the medicines, and the equipment that are required, as well as the psychosocial support that the families need.
Okay, now that you've said that What is your take on the fact that the national palliative care policy is at an advanced level of development? What is your take on that?
That is a big challenge for the Ugandan government because the countries that were, if you look at Africa, Rwanda moved very quickly and they developed their policy, implemented it. Swaziland did the same, Mozambique did the same, Botswana has done the same. Tanzania, if you look at many countries across Africa which came after Uganda, they've gone through the entire policy making process and passed their policy and started implementing their policy. So Uganda has a challenge to ensure that the policy is passed and that it is funded to be implemented right from the patient level to the national level. I think that is a big challenge which the Minister of Health has to work on together with the Minister of Finance and maybe Parliament of Uganda to ensure that we have a well-funded, functional policy that touches every Ugandan wherever they are, and then we can truly say that palliative care, my comfort, when you know that your back is covered.
Now, looking at the region and us, Uganda, other regions, the ones that you say whose policies are actually have already been implemented, how do you assess the performance of Uganda compared to our neighboring countries? Because if we're already operating and people have success stories to tell, yet the policy is still, say, at a framework stage, what have you got to say?
That is a good question. Uganda has been doing very well, and most of the countries have learned from Uganda. Most of the African countries have learned from Uganda. And that is something that we should not take lightly. It's something that we should be thankful for and something we should credit government for. You remember when then Brigadier Jim Muhwezi was Minister of Health, Uganda passed that nursing prescription statutory instrument that allowed nurses to prescribe oral morphine, which is not in was not in any other country. But as time went on, other people have overtaken us. Let me give you the example of Rwanda. Rwanda went ahead, introduced their national policy. They have even set up a system of universal health coverage where patients don't have to worry about payments to get a service. And it's a cross-cutting thing. You go to Botswana. Botswana took 1 year to develop their national palliative care policy, and they even included a clause which allows government to use the national budget to fund hospices to deliver the services which government is not able to do, or to reach places where government is not able to reach. So if you look at some of those examples, these countries have overtaken us. If you go to a country like Kenya, they have been quick to introduce their hospices within government facilities so that they share the resources that they have, and they are able to reach more people in hospitals who need the palliative care service. So as Uganda, we have a challenge. Yes, we are pioneers. We've done a great job, but slowly they are overtaking us, and we need to look at those issues to allow us catch up, allocate enough money, nurture and support the hospices because they are not profit-making organizations. Some of the money must actually come from government because they are doing work that government should have done. So those are the steps that we need to take. Otherwise, we'll be, within the next 10 years, we may not be able to say proudly that we are the leaders because they have overtaken us.
Okay, true to that. Now I'll get to Dr. Jackson Amoni. Very well, and glad that on the panel, Ministry of Health is represented. And thank you for being partners and supporting Palliative Care Association of Uganda. But now, having heard from what Dr. Luika has said, I would like to pose the question to you. He has said it, yes, we're the pioneers, we started it. We've had this story. What plans do we have to put in place to be able to continue modeling the service, but also ensure that these policies are actually implemented and are not left on paper?
Yeah, thank you so much, Sophia. I want to begin by saying that all of us who are seated here and people who are watching us on the TV, we really need palliative care services in one way or another. And as has already been said, palliative care is not a terminal care only. It is the beginning of care from sickness up to bereavement. And that's a long kind of thing. And as Minister of Health, I want to begin by saying we were at the lead But as my colleague said, we were overtaken somewhere. And you know, even in athletics, when you are running, sometimes you rest a bit and you continue running. And I think that's what we are doing. We realize that palliative care is very important, and we definitely put it in the national health policy and subsequently into the health sector development plan. And because of that, we started developing the policy. We had an hiccup where, because of funding, we needed to get a certificate of financial implication. And when you look at this broad kind of palliative care services, the money should be big. And that's where we are. We had a participatory development of this palliative care policy, which is now at advanced stage to be presented to Cabinet. So if it is approved, it will be going to Parliament and we'll have a palliative care policy. But that aside, we also continue to implement a lot of palliative care policies. One, we continue training the specialists. And we have even now created positions for specialists, administrators, so that they continue with providing these palliative care services. So these are ranging from the ministry headquarters up to the lowest level of our health facility. And we have also been continuing to budget for palliative care services. And the major budget goes for the medicines, especially the oral morphine, which we provide. And we have been consistent in providing that money. And I know I'm happy that we are working very closely with our partners and associations. So when we sit like this, we are sitting as one family. Because Palliative Care Association, the African Palliative Care Association, they are very close partners to us. And we talk one voice. And I want to urge that we need to continue advocating for all this if we want to have a meaningful celebration today, that palliative care is my care and my comfort, because we are looking at the holistic provision of service to our patients in the country.
Okay. Now, due to COVID-19, of course, we've come to terms with what is going on right now, like say the new normal. And of course, this new normal is going to affect the normal flow of things. Palliative care is one of those areas that is going to be greatly affected, where you might not be able to provide the services as they are meant to be. What plans does the Ministry of Health have to ensure that this continues and is not affected due to COVID-19?
When you're looking at the COVID-19 service provision, we are looking at how we provide service, both to the people who are affected and the people who are not affected. And we begin from looking at the people who have been affected. And when we discharge these patients, we need even a lot of palliative care services that we should provide to them. And this falls under the mental health and psychosocial support, that some of them, after discharge, we need to follow them up. Because when we look at palliative care, we are not looking at only the pain aspect, but also the other aspect and the involvement of the family. So we have created a way that we need to work with the Palliative Care Association to make a follow-up of our patients. One, we have created what they call a call for life, where we have developed an online follow-up. We call the patients automatically and the patient responds. So we are also trying to avoid the stigma that can be associated with palliative, with the COVID. So when we call them, we keep following them up. And I think that's also another good thing, that it is a part of the palliative care activities that can be done. But besides that, we need to work with the association, that we need to take these palliative care services closer to the people who are in the community, because the people cannot come to where they have been getting palliative care services. So the more we take it closer, the better. And this needs a lot of budgeting by the ministry and the partners so that we can achieve that.
Getting to you, Dr. Luika, again. How have you people tried to support and help people? You know, just a mention of telling a person that, you know, you have to take a patient for palliative care, much as they see that the person needs that service, creates a lot of stigma about it, where somebody thinks now you've given up on them and you're telling them this is it. How have you been able to see that people can embrace and accept palliative care without them thinking the worst about the service?
That is a very broad question as well, starting right from the policymakers to the health workers, to the community, and then to the patients themselves. Because if the patients also don't know what should be given, they may not be able to accept it and take it. Now, as the African Palliative Care Association, we've been engaging African ministers since 2013. We have special meetings with them, and we share what needs to be done. Then they bring in what their countries have done and be able to engage them at that level, at ministerial level. That is the first step. The other thing that we do is working together with the national associations like Palliative Care Association of Uganda to support their activities and reach out to health workers, but also to hospices and patients and the general public, and by holding events like we are having now. The other thing that we've done is also to develop communication material that we share with the national associations, which then in turn share with their general populations. Now, that's not an easy thing because we know that there's an issue of language. Language is a major issue if we are to deal with stigma, if we are to deal with communication. And one of the most costly things now in reaching communities is translating information into their local languages. And that's something that we are working on together with some of the national associations, but which governments also need to work on. That when you are sharing public information, it's not only in English, it's not only in Uganda, but somebody who is in Koboko, somebody who is in Vundibujo, somebody who is in Mbale should be able to hear the messages in their own languages so that they understand and then they make up their mind. So that is something that needs to be strengthened. We are not yet there as a palliative care movement, but it's something that we are to invest in to ensure that we can go through that to deal with the issues around stigma. But also, when people like Imelda come up and share what their experience has been, going through supporting their mother, or even when we hear patients themselves sharing their story, that again helps with the dealing with issues of communication, but also stigma.
Okay. Now I'll get to you, Dr. Dongo. Would like you to help derive from your experience, what is it like in the circles of dealing with cancer patients? Is this a must and part of their package? Or is it something where, you know, as and when they will need the service?
Thank you, moderator. As you heard from Imelda's story, I think now we have a lot of evidence to show that palliative care improves quality of life, and I'm talking about life here, of a person. Provision of palliative care in a cancer patient can help them live longer than we had imagined. At the cancer center, or when you're dealing with cancer patients, we have a lot of challenges. Even before you think of the physical challenges, the fact that you tell a person that in that breast there could be a cancerous lump, it causes them trouble. And I think because of the defects in the way we probably address this, it has led to people dying earlier. Because some people choose to take non-conventional ways of treatment, including use of herbal remedies, etc., and the person ends up dying. But when we introduce palliative care aspects at an early stage, including being able to communicate properly to the patient, to explain what is going to happen, to make them not lose hope, knowing that much as they've heard about the fact that chemotherapy can be dangerous, and we give them the right information, and also letting them know that we'll not let you get into these symptoms. We predict them, we assess for them early enough so that we can treat them. A person goes through treatment without even knowing that they have all these challenges. Recently, there was a story of a young lady, I think it was in Saturday, one of the dailies on Saturday. She was treated for leukemia and she got better. But what she went through was not simple. With this holistic approach to patient care, taking you through symptom control, controlling pain, you are able to take your medicines that would be able to treat the disease and you go into remission. So in cancer treatment, we face a lot of challenges. Remember, most of our patients present with stage 4 disease, where cure is kind of less likely, but many of them actually go through. At the Cancer Institute, we integrated the aspects of care. We may not have a fully fledged palliative care service, but we work with organizations like the Palliative Care Association, of, not the association, but member organizations of the association, Hospice Uganda, the Mulago Palliative Care Unit, and all the nurses and doctors have had certain aspects of training in palliative care. So we use this approach in our patients, and it has helped them to live with the disease, and many of them going through the disease.
Okay. Okay, for you who might have just joined us, you're watching the World Hospice and Palliative Care Day high-level panel discussion on NTV and Facebook, that is on YouTube, and you're also watching the same on Palliative Care Association, YouTube and Facebook lines. But at this particular point, since we have amongst us many people from the different associations, I would like to open up the floor of discussion. If you have any questions to throw to any of the panelists here, the time is now. I would beg for us to be supported by a microphone so that we can have other members within the room here at the Sheraton Kampala be part of the discussion. Please feel free to raise your hand if you have any question, and the microphone will be brought to you. You are at liberty to ask a question to any of the panelists here. Yes, please. Please remember to introduce yourself and where you're coming from.
Yeah, good morning, everyone.
Good morning.
Florence Narutaya Serwada, a palliative care nurse who has practiced for 21 and a half years. I work with the Makerere Palliative Care Unit. This question goes to Dr. Amoni. We are aware that our policy is still, guidelines are still underway. But the challenge we get, I don't know how you are going to help us, is about recognition of nurses. My care, my comfort is the theme for today. How are we going to do this? Because me as a person who is in Mulago, at the forefront of seeing these patients and discharge them. When we discharge them, as these nurses are not recognized or left to do palliative work, or the day, they are left doing their own work. So by the time we refer these patients, we see that these patients, they can't access the service as the nurses, the doctors are doing other work on the wards. Others are deployed away. How are we going to do it to make sure that we get a comfort of these patients? Because when we discharge them and they receive the care, they don't call back. They get information, they don't go to witchcrafts because they have someone who is near them, at least to help with the comfort. How are we going to hope so that these patients are getting their care, Dr. Moni? And when are these nurses going to be recognized as palliative care specialists?
Okay, thank you, Florence. Dr. Moni will respond to that. Do we have anybody else with a question? Yes, please.
Thank you very much, our panelists this morning, and Pikao for organizing this important meeting. My comments and questions go directly to Dr. Emmanuel and Dr. Dungu because of their leadership role within Pikao at the national and regional level. Palliative care is definitely and truly a human rights and public health issue. And maybe this is also a challenge to Mark and the team, that it is definitely a human rights and public health issue. Now, the teams that I see in this room are the same teams that have been in palliative care for the many years. Now, I've seen human rights and public health advocates put governments to account for commitments such as the Abuja Declaration. And I think we definitely need to move with them, because I have had Dr. Manuel comment that indeed we need to get to government, to the Minister of Finance, to allocate more funds for palliative care, to the Ministry of Health, because we know that the hands of the ministry are tied financially. If out of 15% committed funds in Abuja, they are getting only 5 point something, then they can't do everything that they need to do. So we actually need to ensure that we bring human rights and public health people, even economists. Because when we talk Ministry of Finance, we are talking about the economists. When we talk about our palliative care the usual way, they try to question, they try to find themselves, okay, where do we fit here? And if we don't get them on board to see where they fit perfect, to ensure that they know that it is important to allocate funds to palliative care, we will continue to talk, but as long as the people who are involved in physical and monetary policies do not know about this elephant called palliative care, they sit on the right tables and allocate funds, they will not allocate us funds. So I think the challenge is to Pikau and the rest of us in this room, that we need to bring our brothers and sisters in human rights, because we need to challenge. We need to challenge. We need to empower legally. We have, in this country, we have a patient's charter. But to what extent do palliative care patients know their rights? And if they don't know their rights, when do they then come up and say, it is my right to get palliative care, I actually need palliative care, and if you're not giving it to me, it is my right, and it's a legal issue. So I think for me, I would really like Dr. Manuel and Dr. Dung to comment on that, and perhaps Pikau, to what extent are we thinking about this issue and bringing on board the significant others that can help us push this agenda for better success, even in terms of resource allocation? And also, to what extent do our palliative care patients know their rights? And to what extent can they comfortably and confidently ask for the services that they have to get? Thank you.
Okay, thank you so much. I would beg first, because we're running out of time, and what I would urgently ask now is to first have Dr. Amoni kindly respond to Florence on her issue and concern of recognition as nurses in the role that they play when it comes to palliative care.
Thank you so much, moderator, and thank you, Florence, for asking that question. I want to respond that, one, as Emmanuel had said, we had given the statutory instrument for the nurses to prescribe morphine, and it was recognized in Uganda. And for now, that's where we are. But two, we are in the process of restructuring the health sector, the staffing, and it's going to be at all levels, from the Ministry of Health headquarters down to the regional, national, and the lower facilities. We want to create the substantive positions for palliative care personnel, from the consultants, the nurses, everybody. And in doing so, we also want to put the wage bill, so that a nurse does not do palliative care as a hat-on. And we want to make sure that there should be training, and we should train the palliative care nurse in that specialty. And as you know now, we have what they call the nursing now movement. And the nursing now ask the nurses also specialize in their own different areas. And when we continue doing this, we are going to have these nurses recognized. And that will come in the policy which we are about to finalize. Thank you.
Okay. Then I'll ask, I don't know who would like to go first, whether Dr. Dungu or Dr. Emmanuel, on the concerns that have been raised.
Thank you very much, Madam Fatia, for the points you've raised on human rights, and also on the issue of engaging the people who hold the national pass. And I agree with you 100%. We need, in fact, Uganda was the first country to have legal and human rights guidelines, which were done by the African Palliative Care Association, Pikau, and the Ministry of Health. And those guidelines were translated into, I think, 2 or 3 languages locally. So we can use those to engage more people, both patients and providers, and our partners in the legal fraternity as well as in the human rights movement. So we have our work cut out. Secondly, on the issue of allocation, I also agree with you that we need to have more people from Ministry of Finance, Ministry of Public Service, Ministry of, and Parliament together with us, because those are the final decision makers when it comes to money. That comes to the Ministry of Health, from which palliative care draws its money. In July, I think it was on the 3rd of July, I had the opportunity of meeting the Minister of Finance as part of, again, another movement that was pushing for more allocation of money to the Ministry of Health to increase the money to 15%. And I was very pleasantly surprised by the minister. I was not on appointment. He allowed me into his office and he asked, what are the issues? And I said, we need more money to go to Ministry of Health. And he said, for what? And I gave him the facts and he asked, have you put it in writing? I had the letter, I gave it to him. But we need, as a group and as partners, to push more, both at Ministry of Health. I know we have Dr. Amone with us here, and the director with us, but the people who eventually allocate the money, which is Parliament. And I know most of us are voters. So we also need to engage at that level because we are in the right season. As people say they want to go to Parliament or they want to stand as president, what are they going to do for the health sector to make it my palliative care, my comfort? Can they ensure that we allocate more resources to the Ministry of Health so that in turn, the Ministry of Health can work better with the communities, with its facilities, with the districts to ensure that palliative care is available right at the bottom of at the lowest of the community. So I think that's a very important observation that has been made, and it should be both at the African Palliative Care level, which we're already doing, at the Palliative Care Association level, and as well as with all our other partners. Thank you very much.
Okay, Dr. Dungu.
Thank you so much. You know, I like this question because all along when I was coming here, I was looking at palliative care in this country. It was at the top. When we used to go into communities, see patients, give them comfort, including the one they've talked about for 20 years. And now we find that we cannot even afford to do a home visit. As president of the Palliative Care Association of Uganda, it hurts me to see that our member organizations are no longer able to implement what they love most. To see that they're even, they have to reduce on numbers of people who are supposed to help. Bring about the issue of human rights. They can help us to advocate. Just to give an example, if government got about maybe 1 billion or 2 per year and extended it to, say, Hospice Africa Uganda, and they're able to acquire a few more vehicles, and they're able to pay for salaries of a few people, we would have a lot of decongestion at the Cancer Institute. We would have a lot of people happy at home. Ladies and gentlemen, people in hospitals are not comfortable. They prefer to stay at home. They prefer to be with their loved ones. But we cannot let them go. They'll ask now, how will I manage this? So my humble appeal is, if we can extend funding, it can be direct government allocation to member organizations to help decongest the health institutions through funding. The other issue, when Madame Fatia said, I'm seeing the same people. There's an institute for palliative care medicine in this country that trains from diploma to degrees and going for PhDs. They need to be supported so that we train more people and we build capacity in this country to make sure that people understand palliative care, to make sure that the position Dr. Amanda is talking about are filled with people. And now there's someone, but they might retire and we need other people to fill in that place. So We are going to work with human rights organizations to advocate for funding, to advocate for strategies of making sure that we get this. For example, if the morphine preparation unit of Hospice Africa, Uganda, is not given enough funding, and then other, we have a lot of people in pharmaceutical industry, they'll start importing their own morphine in here. We need to make sure that we keep this as a government entity that is fully working to the extent that at some point you can even make long-lasting tablets made in Uganda here. So these are challenges that we have, but we have to forego. So I'll end by saying that access to palliative care is a human right, but still we have people who don't like that idea given to them. You tell a patient that they need to have some palliative care intervention, and they refuse. I am not ready. But I've known it's all because people have different understandings of palliative care.
Okay. We have a few minutes to wind up this discussion, but there are other people who have been following through into the conversation, and I would beg to respect and pass through their comments. Please put this to Ministry of Health representatives. Many of the progressive things that were in place from 1993 have had to be reduced or closed because of COVID, and others because of the tiny budget from Ministry of Health for palliative care. University students at Makerere no longer get experience in the hospices, while more than 90% of cancer patients are in the communities and they need assistance, but cannot get it because of financial difficulties. Their concern is that the doctors of the future are not aware of what is going on in the communities all over Uganda. Because I think this particular service of the face-to-face, door-to-door is no longer effective. Then there are like services like home care, daycare, and other trainings for community volunteers, they feel do not exist anymore. And of course, Dr. Amoni, you'll be able to respond to that very briefly. The others are questions via Zoom. This is from Professor Anne Merriman. She's following through on the conversation. It is good to have palliative care in hospitals for many reasons, not least to get the other specialists to understand that caring is so necessary, not just curing. However, with 57% of the population not reaching health services and more than 90% of cancer patients not reaching cancer treatment, we need our doctors and health workers to realize that all these people are suffering in the community. They need exposure to palliative care services, managing patients in their own homes, in their training. Otherwise, they become hospital doctors only and do not even realize the gross suffering within communities. Please comment. You can see that the issues that are coming out are almost pretty much in line and the same. Then there is from Dr. Doreen Agasha. She says this is specifically to Dr. Amoni. Thank you so much for all the support you as an individual and as a Ministry of Health has endeavored, the PC fraternity. The Ministry of Health has greatly been supported by donors to deal with health challenges in Uganda. And that is the reason for the great strides in the right direction realized in malaria, TB, cancer, emergency medicine, etc. Has the Ministry of Health sought out donors out there to support palliative care as a major national concern? Is that something that has been delayed by lack of a policy? How do we get national players to think of palliative care also? I beg for us to utilize less than 10 minutes to be able to respond to the concerns that have come through. The ones that have been addressed by Dr. Merriman, I don't know who would like to go on it, but Dr. Amongin, I think you should take on the concerns that have been raised in your direction first.
Yeah, thank you so much, moderator. I want to begin by talking about the issue of COVID and the low budget. As I've already mentioned, COVID has really interfered with many of the activities that we are doing because we can't access our patients. And this also goes to the little money that we have. And we have already mentioned that the Ministry of Health does not have enough money. And this is not only for the Ministry of Health. As has already been said, if money can also be extended to our association, because the associations and the partners, they do a lot of work, and we work as a team. I'm sure the Palliative Care Association of Uganda, the African Palliative Care Association, if they had enough resources, the work would have gone so much. And this support to the hospices in the different hospitals would have been an asset to us. But because we don't have that, the home care services have been so much reduced in number. And what I want to say generally is that the policy is in development. And very soon, my director is here. We have just been discussing it this week in our quarterly review. The minister wants it out. And that's one of our target, that within the shortest possible time, the policy should be finished. We also want to say that the training that we have been doing, we're going to continue with it. And the different types of courses that are available to make sure we have enough specialists and in different categories. And we also want to recruit these specialists, because it is not good enough to train people and leave them in the community. We want to train them and absorb them so that the services are going to be given to the people that need it. Finally, we want to see that most of our hospitals, they have palliative care units. So that would be the referral area that they can go to the community, and the community can refer these patients to them. And when we do this, I think we'll have a two-way movement of seeing the patients from home and referring the ones that need treatment in our health facility. Finally, we want to lobby seriously for funding, because without a dedicated fund for palliative care, we may talk and will not achieve what we want. We want to advocate both to government, we want to advocate to donors, and we want to advocate to other partners that the support should come not only to the Ministry of Health, but also to the association that with whom we work, so that we deliver the services that we want to the palliative care patients. Thank you so much.
Okay, since we're running out of time, I would like to start from this side. Imelda, can you please share your winding up remarks?
Yeah, thank you so much. My winding up remarks, almost what I wanted to bring forward has been said, has been answered. Because, for example, I wanted to talk about, as much as we train the nurses, I would like to see, I want to see training, education, awareness given to the caregivers. Because like you've been sharing, the moment you're told you have cancer, you have this illness, and there's no cure, you lose hope. You feel you're going to die the next day. So the next person who is going to feel there's no hope is the caregiver. So I want to see Palliative Care Association doing more trainings and awareness to the caregivers. Then the counseling. Before, like you do it in HIV and AIDS. One is asked why he thinks he's positive, and then afterwards, what will you do after finding yourself positive? So I think it's the same counseling that is needed in these terminal ill cases to try to reduce the stigma, the traumatizing situation in these patients. And then the financial support, if I had other caregivers here, they would really testify to you how much money they've spent and how much debts. Like, for example, at the airport, we have money lenders. Any moment you're told your mom is down and you have to rush into her to Zambia or to Mulago, go to run to a money lender. You'll find all these caregivers are in debts. So I don't know how government can do this, that maybe at one point in time, as this policy is being formulated, we get this support, these patients get this financial support to reduce the stress on the caregivers. And especially the elderly, poor, sick, if these three can go together, elderly, sick, and poor, those who cannot afford it. And then I want to talk about the policy, but I've just got the answer that is already in the process. And specifically for, I would like to see the standalone policy on palliative care so that we see the specifics. We don't go by the World Health, the Ministry of Health. We have one particular one for palliative care. That will be great. Then integration, kind of dispensing units. Let's say we have palliative care in, let's say they call it health center for this one local. Because there are very many people out there sick, and they are going to the hospitals, the clinics, and they do not get that care that I've been getting, like I've told you. So I want to see it down there, and so that everyone knows. Maybe the other part of the policy should be the one I've already talked about, having it universal. Like we have people who prepare for old age, have saved maybe with national security, social security. I would like to see the government, Dr. Moni, have that universal health care for all, and especially at an age where you've already retired and you need that help. Thank you, sir. Thank you.
Okay. Dr. Dungu, thank you so much. The reason as to why she's responding the way she is, for you who've just joined and missed out on the discussion, she has been she's a caregiver for a period of more than 20 years. So it's quite amazing to see that she's continuously going strong on it and has even done her research and possibly compared notes to what is happening elsewhere and would like to see the same service offered here in Uganda. Dr. Dungu?
Well, thank you very much, everybody, for being part of this as we commemorate World Hospice and Palliative Care Day. My humble appeal is going to be about making sure that palliative care service provision continues. I want to call on the general public. You know, if we say my care, my comfort, it tells us that we all have to take responsibility. I've seen in other societies where people regularly donate towards the cause, people donating towards research, philanthropists coming up to support government. I think we need to come out. There's so many of you out there who have money that you can actually share and help people live quality life. Let's come together. Let's work with human rights organizations, not to look at this as a punitive aspect of it, but as a voice to speak for those who cannot speak, so that we all embrace palliative care. And to you, person who is a recipient of the service, I mean, we are all potential recipients, let's not look at palliative care as only meaning that you are dying. We are using this as an approach to help a person live for another 20 years and living a quality life. So let's all embrace palliative care and we continue moving. Thank you.
Okay. Martha? Please turn on your microphone, Martha.
Thank you. Thank you, the moderator, and everybody who has been in this discussion. My concern and my message is I'm praying very hard that maybe at the end of this year, this policy will have been produced. Every time we come to meetings like this, they say the policy is in the process. Hope by the end of this year, the process will be finished. That's one thing. Second thing I'm praying very hard is these nurses who are training and the doctors, and they should be also recognized, as Florence was saying, so that when they go back, they do the work which they have studied, and they give this care, this comfort to the patients. And I would ask the general public to understand, because in our work, when we are giving out our care and our comfort, people think that we have a lot of money. We don't have a lot of money, but we have a lot of love and we have a lot of sacrifice we do so that these people can get what they need. Because even when patients are supposed to go to Mulago to get chemotherapy, they need money and they don't have it, as she has already said, Chonjo, that there is no money and people have to go to borrow money. Sometimes when we have money, which has been given to us by donors, we always give it back. All we need is our transparency that if you get money, please put it where it is supposed to go. Thank you very much, everybody.
Dr. Moni, we just have like 5 minutes to wind up with the panelists. Please, your winding up remarks.
Thank you so much, moderator. As I said, we are committed to ensure that the policy should not be talked about again. in another gathering like this. We commit that it's going to be out in the shortest time. I also want to tell the viewers that today somebody needs palliative care services. Tomorrow it may be you. We want all to be committed in ensuring that this services is available when you need it. We want to call upon everybody to support palliative care. And be it a donor, be it an individual, be it an institution that you can be able to donate, please donate to this noble cause of providing palliative care services. To the health workers, palliative care is not only for nurses. Palliative care is for all cadres of health workers, from the doctors, the nurses, allied health professionals. And we are going to create those positions so that you will be in a substantive position, and when you study at in the different courses, you should be recruited and you provide the service as is required. I want to end by thanking so much Palliative Care Association of Uganda for making it possible that we are working with Ministry of Health to celebrate this year's World Hospice and Palliative Care Day with the theme of palliative care is my care and is my comfort. I thank everybody for coming to join us in this celebration. Thank you so much.
You're welcome. And finally, Dr. Luika, your winding up remarks.
Thank you very much. I have 4 points of appeal. One goes to all the arms of government, to Parliament of Uganda, Ministry of Finance, to allocate more money to health and build towards the 15% so that the Ministry of Health can meet its need, including palliative care. That is one. Secondly, to the Ministry of Health. We know that from March to September, we've not had people fly out. Maybe we can start by saying that all the money in the budget that was allocated for travel abroad is given to hospices so that we can deal with the suffering that is going on in the community. People are poor. I've had my mother in the Heart Institute in the last few weeks, and let me tell you, some people just give up. When they tell them that this needs to be done, they just give up. People have no money, and we need to appeal to ministry also to look at that. The other one, they will ask us, where shall we get the money? We can also increase taxes, sin taxes on alcohol, the beverages that we like, the Coca-Cola, the Pepsi-Cola. The Ministry of Finance can increase the taxes on those items which make us sick and give that money to health. And then finally, to the Palliative Care Association of Uganda, I want to make an appeal. Let us set up a national palliative care fund. The African Palliative Care Association is willing to work with you so that we set up a national palliative care fund that can annually allocate money to hospices, even as we engage government to give us more money. Thank you very much.
Okay. Thank you so much. Thank you so much to the panelists and for all the knowledge that you have enriched us with. And thank you so much to the online people who've been able to watch through live on YouTube and Facebook, that is with NTV, and as well watched live through Palliative Care Association of Uganda, YouTube and Facebook. I'd like to thank you so much, panelists. Please give them a clap. At this point, I would like to invite again Mr. MacDonald Mwesigwa, the country director of Uganda of Palliative Care Association Uganda, to come and take through from here, because what is left is his responsibility to take over. And the panelists, please, you can step down. Thank you.
Thank you so much, Sophia. I know we have very few minutes left, but we are going to do this as protocol dictates. Thank you so much, everybody who was online. And thank you so much, Fatia, for the great question. We invited actually people from the human rights circles that we work with, and we want to make sure that now that you are there, that you carry the banner, you carry the light, and that we make sure that we are with everybody who matters. We have our colleagues from ISA in the room, and I may not say it, but at one time, actually, somebody suggested to us at the Secretariat that why don't we take government to court? And I was like, this is serious. So thank you so much, everybody who has been here with us, I appeal to you once again, like you heard from how we started up to now, we still want to make sure that we make a contribution as we wait for the government to make sure that they do the contribution, government at Yambe, for us, what have we really put in place. So we have given you some platforms that you can contribute. And these platforms, some of it are in your folders. Contribute something. We were able to raise some money to give to hospices, to all of our members through donations from people. This was 10,000 USD. 10,000 is about 37 million. And this is not to say that people cannot do it once they are committed to do it. So whatever you can, for now, let's do it, and let us all hold our government accountable. We are all in the season of electing our leaders. We have written to the NRM people who are drafting their manifesto. We have told them we want to see in your manifesto that palliative care is part of the things you will support. Please hold your leaders accountable as well. At this moment, I want to request Dr. Monet, now not as a panelist, to come and welcome the minister to speak to us as we close this meeting. Thank you so much.
The representative of the Honorable Minister of Health here present with us in the capacity of the Director of Curative Services, the members from Palliative Care Association of Uganda in your various capacities, members from African Palliative Care Association, the different associations and auspices in the country, partners, colleagues, ladies and gentlemen. Today, as we celebrate the World Hospice and Palliative Care Day, we are privileged to have Dr. Charles Solaro, who is here to represent the Honorable Minister of Health. And he has a speech from the minister. I'm sure he will tell us the details. And I want to take this single pleasure and opportunity to invite him to come and address us on this very important day. Dr. Charles Solaro.
Thank you, Dr. Mone, the Executive Director of the African Palliative Care Association, his colleague, the ED of the Palliative Association of Uganda, the Board President of PICAO and its members, the Palliative Care family, the founders, Professor Anne Merriman and Rose Kiwanuka, ladies and gentlemen, on behalf of the Honorable Minister of Health, I want to bring an apology from the Honorable Minister, who could not be here, but she requested me to represent her. So today, 10th October, Uganda joins the rest of the world to commemorate the World Hospice and Palliative Care Day. And the Minister of Health is pleased to join all palliative care actors to commemorate this day. I, in particular, join all of you to stand with everyone living with a life-limiting illness, all the families who are offering care, and the health workers who offer palliative care, even during this challenging time of COVID-19 pandemic. The World Hospice and Palliative Care Day is a unified day of action to celebrate and support hospice and palliative care around the world. And I'm sure the panelists have actually represented this very well, and the message which they have definitely communicated is clear, and so we just need to be able to follow up some of the actions from that. The World Hospice, as I would say, it's a unified day, but also you know that Uganda, we have actually marked this day because we have been a model for hospice and palliative care, not only in the region, but globally. And I think this deserves a clap. I extend my appreciation to all champions of palliative care that we have worked with this to register this number of milestones. The worldwide theme for the World Hospice and Palliative Care Day 2020 is palliative care, it's my care, and it's my comfort. Government acknowledges very well that universal health coverage can only be achieved by ensuring that promotive, preventive, curative, rehabilitative, and palliative health services of sufficient quality are effective and available for all those who need it. At the 73rd World Health Assembly, it was stated that palliative care is an essential part of universal health coverage, and lack of access results in serious health-related suffering. This time comes at a time when the entire globe is faced with COVID pandemic, at the time when we've registered more than 80 deaths due to COVID and continue to have a growing number of critically ill in high dependence units and intensive care units. I want Hasten to mention in here that therefore now the strategy changes that we need to be able to shield these vulnerable groups from infection from COVID. Because as you look at that, definitely those who have life-limiting conditions are also at a very high risk of developing very severe severe COVID. And I'm happy with the Palliative Care Station of Uganda. You have clearly articulated this of what the workers need to do. You have also gone ahead and developed operating procedures so that you protect these people. Even if you visit a cancer patient, you should protect, both to protect the health worker, but also to protect the patients. And this is quite important. Palliative care is a vital part of COVID response by alleviating suffering for people of all ages by managing the severely ill and critically ill with breathing difficulties, facilitating communication, end-of-life care, bereavement, support across all settings, including hospitals, communities, at home. Based on experience from other global viral pandemics, palliative care supports the health system, the health workers, and the communities to alleviate suffering, including the end of life. According to WHO, palliative care is an approach that improves the quality of life of patients, their families facing the problem associated with life-threatening illness through prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems. And this should include physical, psychological, and spiritual well-being. And at this point, I also want to mention that as we celebrate this day, you're also aware that today is the World Mental Health Day. So you look at that, probably the framers of it put that you need to be able to look at life in a holistic manner. Palliative care for both adults and children, and WHO has provided a definition of palliative care for appropriate for children and their families. So we need to look at that. Palliative care is needed both by adults and children. So palliative care for children is the active total care of the child's body, mind, spirit, and also involves giving support to the family. It begins when the illness diagnosis continues regardless of whether or not the child received treatment directed in the disease. And health providers must evaluate and elevate physical and psychological suffering. Effective palliative care requires a broad multidisciplinary approach that includes the family and makes use of the available community resources, and it can be successfully implemented even resources are limited. It can also be provided in tertiary facilities, in communities, and even in children's homes. There's no better time to embrace palliative care than this time when the entire globe is responding to the deadly pandemic, COVID-19. As groups which are at risk of developing severe disease and complications include mainly those who are enrolled in palliative care or those who might need it anytime. The groups of risk developing severe disease and complications and definitely may require palliative care are those above 65 years, those with heart conditions such as history of heart attack or stroke, patients with diabetes, cancer patients, whether or not in chemotherapy, those with advanced liver disease, persons living with HIV/AIDS, lung diseases like asthma, TB, and those with chronic obstructive pulmonary disease, kidney disease, and severe acute malnutrition. The majority of adults in need of palliative care have chronic diseases, such as cardiovascular disease, and this represents about 38.5%, cancer patients about 34%, and other diseases about 10.5%, and AIDS 7.5%, and then diabetes at 4.6%. So I want to mention that palliative care is just more than pain relief, because sometimes when we talk of palliative care, we limit ourselves just to pain. It provides relief from pain and other distressing symptoms, affirms life and regards dying as a normal process, intends neither to hasten or postpone death, integrates the psychosocial and spiritual aspect of the care, and offers support systems to help patients live as actively as possible in their own. Use a team approach will enhance quality of life and maybe positively influence the course of illness. It's applicable early in the course of illness, so we should not wait that we only want to introduce palliative care at the end of the life cycle. And according to the WHO and the World Palliative Care Alliance, it's only 1 in 10 people who need palliative care for pain, symptoms, and stress are able to access it. It's also estimated that every year more than 40 million patients need palliative care at the end of life globally, and 78% of them are in the low and the middle income countries. And children represent 6% of them. At home, back home in Uganda, only 11% of those who need or pain control within the wider context of palliative care access it. And this has been worsened by the COVID pandemic. As you're all aware that during the lockdown, people were not able to access. And particularly from April to May, there was a decrease of about 50% of patients could not access their palliative care services. I also want to mention that Uganda manufactures its own oral liquid morphine at Hospice Africa, Uganda. The government supports this process by importing the powder, and NMS distributes it. This is an important medicine for management of moderate severe pain among a patient with life-limiting illnesses provided by government of Uganda in patients in need of free of care. As I conclude, Uganda needs to know that all national and regional referral hospitals are offering palliative care. A large number of general hospitals and health center force are also offering services. The Ministry of Health is working with the Palliative Care Association of Uganda and has accredited more than 225 health facilities to stock and prescribe oral morphine. We know that about 30 districts do not have palliative care services, and we are working with the PICAO to reach these districts. And these are mainly the newly created districts. So we'll work on and see how we can have 100% coverage. All accredited health facilities are urged to order and prescribe for every patient who needs it. We want to make sure that morphine and other essential palliative care medicines get closer to those in need of more health care, up to health center force. We worked with the palliative care to come up with a list of medicines, which definitely we put in our essential list, particularly for palliative care. In terms of human resource, the ministry worked on to start the commencement of a diverse diploma in palliative care nursing at Mulago School. And this is one way of really scaling up palliative care specialists in this country. But you are aware now that there are courses at degree level, at master's level, which are offered for palliative care. It's now for the ministry to work with means of public service during this restructuring process to make sure that these positions are officially available so that we can be able to recruit these specialists. So the country needs more palliative care specialists at master's level, as most of those offering care in this country. The Ministry of Health continues to pledge its support to the palliative care fraternity, as it has been before, and the Clinical Services Department has a division of palliative care, which handles palliative care services. And this is supposed to be headed by Assistant Commissioner. Finally, as all of you are aware that access to health is a human right, it's also in the same vein that access to palliative care is a human right. I urge all the partners and friends of palliative care to come and support the government to be able to execute this task. I've read the speech on behalf of the Honorable Minister for God and my country. Thank you very much for listening.
Thank you so much, Dr. Oraro, the Director, Curative Services in the Ministry. We have come to the end of our high-level discussion, but like I said at the beginning, it is the beginning of a virtual Voices for Hospice engagement. It will transition from being live with NTV, and it will go to the PICAO Facebook account, and people are already on Zoom, so you may need to sign in Zoom for those who got the link. In case you didn't get the link, I request that it will be projected. We had prepared a special message from direct stakeholders right in the community as a short video to give to you as a take-home message. So I'll request that the people who will play that after we have a closing prayer. I want once again to say thank you so much for coming. Thank you so much, the Ministry of Health. Thank you so much, every panelist, the board members of PICAO, all the members of PICAO that are present here. And in case you are not a member, kindly do not go without renewing your membership at the table. Thank you so much. We had Olivia on sign language. I think that one needs a clap. She's been able to interpret for our friends. We had invited the Uganda National Association of the Deaf, and we work closely with them. So they were online. Thank you so much, the team, the staff of PICAO who make this work be. Thank you, all the media people. Thank you, the hotel, for hosting this. And I request at this moment that since Dr. Jambo was quiet throughout the session. She can come and pray. And after the prayer, we will watch the video with a take-home message, and then we'll transit to the other function. I thank you.
Good afternoon, everyone. Good afternoon. It's still morning. Okay, good morning. Okay, that's why you're quiet. All right, let's pray. Mighty and everlasting Father, we thank you for this gathering. We thank you for the World Hospice and Palliative Care Day that we have marked today. Thank you for this commemoration, even as Uganda joins the entire world to mark this day. It is a day that you are concerned about because it is for the cause of those who are suffering with life-limiting ailments and conditions that really need support from every corner. Lord, today we lift our voices to you to ask you to intervene and support your people through the many organizations and individuals that can be able to give in their funds so that we reach those who are suffering and be able to give them the support that they need. Lord, I want to thank you for every stakeholder. Thank you for Ministry of Health. Thank you for the government of Uganda. Lord, I pray that everyone will embrace palliative care and do as they are supposed to do. I can't fail to appreciate you for PICAO, for APCA, and every other stakeholder in this. That, Lord, may you continue to give them wisdom and give them courage and give them the grace to carry on this noble job of supporting those that really need to be supported. Lord, I pray that even as later we'll be dispersing from this place, may you go with us and may you take care of us, even as we plan and strategize on how to support your people. We love you, we thank you. In Jesus' name we pray. Amen. I think my role is done. I'll hand over to Mark. Okay.
Please forgive me for coming back. There is a group photo, and we will kind of social distance here and have the photo, and it will be done. Thank you. The video.
naye ng'obulumi ebizibu bwonna bwava mu binywa n'okusannyalala. Bunoonyezebwa okumala ebbanga, kikwe kiva, ekisooka ne kibula. Kutuusa lwe nali mu ddwaliro, bwe ne bazuula nti kiina kubanga kiva ku kino, bana prostate cancer.
Banzuulamu kansa ow'omumwa gwa nnabaana. Obujjanjabi nasookera ku bwa kkemo. Nenfuna ddoozi zaali 3. Kale awo obusobozi bwali nga bubuzeemu, nenzirayo nga kkemo sikyamusobola. Ne banziza ku treatment y'okkalirira mulago. Kati treatment y'okkalirira bwe yaggwaayo ne baŋŋamba okuddayo. Kati bwe naddayo oluvannyuma lw'emyezi 6 ne babeera nga kale mulago nga ŋŋenda ng'olumu dokita tumusangayo, olumu dokita n'omulaba. Kati wayitawo emyezi emirala 6 nenzirayo nendaba nga sikyasobola transport.
Obulwadde mbeera yange neebaza okusooka aba palliative care olw'endabirira ennungi gye bandabiridde emyaka kati giri mu 5 gye mmaze nga ndi ku ndiri defule bedridden.
Nandibadde ngamba kati ng'abo abakulu ba gavumenti abatuusa amaloboozi eno basobole okuwaayo nga tuwaddeyo ebirowoozo basobole okubituusa amalwaliro gaffe agatuwa obuyambi basobole okukola ki obutabulamu eddagala nve nga tusobola okufuna eddagala buli omulwadde walifunye wali agalidde tuleme kubeera nti ate bw'ogenda nti ate teririiwo ate bw'ogamba nti nno ngenze nti ate bakwaddeyo lya nnaku 2 nti ate onadde nkya
n'okusinza ku mulimu gwekikoze nandisabye oba nandowooza nti gavumenti yandibadde efaayo nnyo okuwagira ebibiina bino bw'ebitongole bino olwa saaviisi gye biwa balwadde eno wansi nga babateekamu obuyambi bakati tugeze waliwo oyinza nabo bakubira nga tebalina fyuwo nosanga nti nno tebasobola kutuuka kyokka nga gavumenti yandibadde awo ezibawo nebawa obuyambi ngaobwo nebasobola okutuuka kuba kati bo bano buliwo bakubira bafaayo nnyo okumanya omulwadde embeera gyalimu era ne bajja nebakutuukako ne bakugira ekitasoboka mu kugamba nti mubulalo bwa gavumenti ojja kukubirwa dokita nti kati ndibwe nti seesobola anajja era gayiiya kyonna kyogira kyosobola ojje kati nze bwe mmaze emyaka 5 nga ndi wansi neebase nga n'abantu bange abanzijanjaba kunsitula obusituzi okunteeka mu mmotoka nakyo nga kizibu ate nga ne mmotoka ogenda okuyinjiramu nti nno bakutwale ojja kutuukayo nga wenooyebye kati bino ebitongole ebisobola okutuuka wansi kyenva nsaba gavumenti ebyongeremu amaanyi olw'omulimu omulungi bwe bikituusizaako